Well, good afternoon, everyone. Happy Tuesday. Thank you for being here with us. We're excited to have you on the webinar and hopefully sharing some really insightful knowledge, tips, tricks, best practices from some great learning at Advocate Aurora with each of you. I'll go ahead and share my screen. My name is Zach Henderson. I am the Director of Education Elect from the Wisconsin HIMSS chapter. This webinar is in partnership with Wisconsin HIMSS and the Greater Illinois HIMSS chapter. So thank you for being fantastic partners to work with our Greater Illinois friends. We won't talk Packers and Bears, but really happy to be with you here today and really excited to share this wisdom with everyone. I went ahead and shared my slides. Betsy or Chris, if one of you could just give me a thumbs up if you can see them. Looking good, marvelous. A couple of housekeeping items before we jump in and get started. We always are looking for new members and folks who are interested in being involved. If that is you, or you think at the end of this, wow, this was so fantastic, I'd like to help with things like this in the future, please feel free to reach out to the Wisconsin or Illinois, Greater Illinois HIMSS chapters. We would love to have you involved. Because this is a webinar and there's a lot of us on this call, we're going to have everyone muted throughout the presentation. That doesn't mean that you can't ask questions, though. There is a Q&A function available to you in Zoom. So if you want to go ahead and ask a question at any time, feel free to open up that questions box and type your question in. We will hold questions until the end of the presentation today, and then we'll try to answer as many as we're able. We will also send out some information on continuing education credits for those of you with HIMSS credentials that will be sent after the webinar today, and it will be sent to those who take the survey. And we'll talk a little bit more later on about the survey, but it will pop up at the end, and we ask that you please complete that short survey. It does help us continue to improve the programming that we provide. We'll also include an email recording of this presentation for you as well. Enough about that from me. I'd like to introduce two of our panelists, or two of our presenters today, Dr. Chris Jamerson and Dr. Betsy Winga. Dr. Jamerson currently serves as the System Vice President and Chief Medical Informatics Officer at Advocate Aurora Health. If you're not familiar, Advocate Aurora has 26 hospitals and over 500 outpatient locations throughout Illinois and Wisconsin. In his role, he's responsible for the electronic health record and the related information technology systems that interact with the EMR across all care settings. He works collaboratively with a talented team of physician informaticists at AAH in the areas of ambulatory, inpatient, perioperative, and population health to develop solutions for care across the healthcare continuum. He also serves as an interface between clinicians, operations teams members, and health information technology. Previously, Dr. Jamerson served as Ambulatory Chief Medical Informatics Officer at Advocate Aurora Health. He was responsible for that, and including during the COVID pandemic. In 2018, he successfully spearheaded the large-scale implementation of Epic in the Illinois Medical Group, which brought over 250 sites of care and over 2,000 providers live on the same day. Throughout the COVID pandemic in 2020 and 21, he had primary responsibility for implementing rapidly emerging clinical guidance and decision support around COVID-19 into the EHR at the system level. A little bit about him personally: he studied Latin and Ancient Greek at the University of Virginia before attending medical school at the Medical College of Virginia. He completed his pediatrics residency at Memorial Health University Medical Center in Savannah, Georgia, and he is board certified in general pediatrics and clinical informatics. Outside of work, he enjoys spending time with his partner of 18 years and their 2 rescue dogs, lifting weights, playing Nintendo games, both the new and the classic, watching stand-up and improv comedy, reading comic books, and keeping up in the latest in personal technology and electric vehicles. Welcome, Dr. Jamerson. We also have with us Dr. Winga. Betsy Winga is a CMIO and Vice President for Medical Informatics at Advocate Aurora Health as well, focusing on ambulatory care and virtual health. Her primary projects include schedule optimization, physician engagement, workflow development, and virtual health. In addition to her CMIO position, she continues to practice clinical medicine as an OBGYN in Manitowoc, where she served patients full-time from September 2005 to January 2018. At the beginning of the COVID-related public health emergency in March 2020, the virtual health program at AAH was in a pilot form, and under the leadership of Dr. Winga was rolled out to the entire organization, including 5,000 plus clinicians in addition to multiple other departments in only a few weeks. To date, Advocate Aurora has completed more than 2.1 million virtual visits by more than 4,000 unique providers. Not only does Advocate Aurora provide patients on-demand and scheduled video visits with primary care and specialty clinics, but they also offer multiple specialty options, including genetic counseling, occupational and physical therapy, and diabetic education. Inpatient virtual health has also been developed to allow for virtual consults, virtual family conferences, and virtual interaction. In addition to her other COVID-19 work, Dr. Winga assisted with the design and scheduling system for vaccine clinics at AAH, which included 31 mass vaccination sites across both states, 100% online scheduling and consent processes. They've successfully administered more than 1.1 million doses of the COVID-19 vaccine to adults and children since December of 2020. A little bit about her personally. Dr. Winga received her BS in zoology at Iowa State University, completed medical school at the University of Iowa, and her OBGYN residency in Grand Rapids, Michigan. She earned an MBA with a healthcare emphasis through West Texas A&M in 2021, and she is board certified in OBGYN and clinical informatics. She's a certified Epic physician builder with additional certifications in analytics, orders, and questionnaires. And of course, the fun personal details, she is married with 2 boys in college, 2 dogs, and a horse, and enjoys reading, cooking, hiking, horseback riding, and downhill skiing. Welcome, Dr. Winga. With no further ado, I'm going to go ahead and let Dr. Winga request control my screen, and they are here to share with us today about controlling the chaos, optimizing the InBasket.
Yeah, good afternoon now, everybody. Thank you. Thank you for the introduction, Zach. We are going to be, as Zach mentioned, talking about some optimization work in our InBasket that we did. There we go. Just want to let you know that neither of us have any disclosures and learning objectives. We wanted to provide some concrete examples of some quick wins with respect to InBasket volume. We wanted to describe kind of a little bit of what we do with the analysis and an application of expiration dates for notifications, and then talk to you a little bit about our plan for continuing and maintaining the improvements in the InBasket oversight. Chris.
Okay. Thanks, Betsy. Zach mentioned some of this already. This is the footprint of Advocate Aurora, or what is now formerly known as Advocate Aurora Health in Wisconsin and Illinois. As some of you may have heard, we recently completed a combination with Atrium Health in the Southeast, in the North Carolina, South Carolina, Georgia, and Alabama region. So we are now Advocate Health Midwest region. So lots of changes happening. We've been through this before, both Betsy and I, through the Advocate and Aurora combination back in 2018. So this is kind of old news to us, but this is just our footprint. Basically, we doubled in size with the Atrium combination. So you just double all these numbers, you get a pretty good sense of where we're at now as an organization. And with our combination, we become the 5th largest not-for-profit health system in the country, which is kind of intimidating. Next slide. So I wanted to talk a little bit about where we were and how we decided to work on this project, just a little background, and then Betsy's gonna give us some even more detailed background on our own analysis internally. So one of the things that we participate in is the Class Arch Collaborative, and we conduct the survey every couple of years to see what our providers' experience with using the EHR is. And as you can see, this is our 2019 data. So this is when we were not fully live on Epic across all sites yet. We were fully live in Wisconsin and partially live in Illinois. We had our ambulatory sites all up on Epic and a few of our inpatient sites, but most of our inpatient sites, our hospitals, were not yet live on Epic. And you can see where we ranked compared to other organizations. Not terrible, but not great either. Just kind of so-so. But if you go to the next slide, you'll see we resurveyed after we were fully live, and you can see that what our raw score was, and then how we compared to the overall collaborative, how we compared to other Epic organizations, and how we compared to large health systems. And that number about appropriate InBasket volume, because they did change the questions, they got a little more detailed in their questioning about InBasket volumes in the 2021 survey, 2 years later when we resurveyed, so we got some additional data, but we were in the 100th percentile for large health systems. So you would think maybe there's no work to be done here. But what Betsy's going to explain in the next couple of slides is that there actually was some work to be done, and that perception equals reality. Take it away, Betsy.
Yeah, so, I don't know that I've ever been in the 100th percentile for anything, and it's so very true. So perception does equal reality, because when we looked at our signal data, when we looked at all specialties, the InBasket messages received and the time in InBasket compared to our other Epic peers in the United States, we were not doing very well at all. We were actually close to the top quartile. And so Signal is, for those of you who aren't on Epic, Signal is a way for us to gather statistics that are between our clinicians and how they interact with their EHR. So it's not anything to do with patients or patient information. It's how do the physicians and APCs and residents and whatnot, how do they work? What are their efficiencies within the EHR? So if you look at all specialties, we were not doing very well. If you look at primary care, we weren't doing very well. And if you look at the medical specialties, we're doing, maybe, not still quite so well. And so, what this all really, and then our surgical specialties, same thing. We're in the bottom quartile for total messages received. And so, for whatever reason, we, from a pure number standpoint and a comparison standpoint, we were not doing well, but somehow our users felt like we were really doing a good job. But after looking closer at this data, we were like, you know what, we can do better. They may think that we're as good as we can get, but we can do better than that.
So based on the review of the signal data, and then just talking to our frontline clinicians, which we have a lot of venues to do that in medical and clinical informatics in our organization, we realized that, the way people responded on survey, although nice and certainly gives you some bragging rights if you want to brag about it, we didn't want to rest on our laurels and say, well, that's great, done, as I mentioned earlier, no need to go any further. And B, to look for other opportunities for improvement, because we knew in those conversations with frontline clinicians that there were still struggles with the InBasket, with volumes of messages, with the types of messages being received being redundant or felt to be unnecessary for one reason or another. And we really hadn't taken a hard look at this since the Wisconsin side of the organization had gone live on Epic in any comprehensive way. And we sort of had, as Zach mentioned in my introduction, our outpatient, our ambulatory go live in Illinois was under a very brief time frame, like 6 months, to bring all those providers live all at once. And so we didn't have a lot of time to do the comprehensive look. We had to adopt a lot of build that was either Epic Foundation build, or in this case, build that was for InBasket messages and what was sent to providers in baskets, clinician in baskets, from the legacy Wisconsin build. And that's not to say their build was bad, it just hadn't been reviewed in a while. Then this was an opportunity to take a fresh look at that. So we identified 4 opportunities: addendum notifications, canceled order notifications, ADT notifications, so admission, discharge, and transfer notifications, and then an overall InBasket tune-up, which if you are on Epic, you may be familiar with Epic's tune-up reports. And we really started, once we were fully live across our organization, to dig into those tune-up reports and take full advantage of the fact that Epic can produce those for us and look for opportunities for improvement. And we'll talk more about that as we go. So for addendums, because Epic is an encounter-based system, as many of you know, and thus we are an encounter-based organization, every time someone touches that encounter, once it's been signed, it creates an addendum, which the system then generates a notification to the owner of that encounter. That's not necessarily always a good thing. Typically, most of the time, what we found when we investigated this is the addendum notifications that were being sent automatically by the system were a nuisance. So we worked with our HIM, our Health Information Management, and our compliance colleagues to understand what really constitutes an addendum that requires notification and what doesn't. And most of the things that would require a signature after an addendum were things that were done by the owner of the encounter in the first place. So they didn't need a notification about an addendum. And then the things that weren't done when the encounter was touched, the things that were done when the encounter was touched by someone other than the encounter owner, typically were not things that from a compliance or HIM standpoint required the encounter to be re-signed and finalized. So we were able to eliminate quite a few of the addendum notifications. And when I say quite a few, you can see we basically brought it down to 0. And now the only addendum notifications that are generated are ones where someone purposefully sends a addendum notification. They have a strict purpose for why they are sending it to the provider. We have no more system-generated addendum notifications going out, which has really cut down on that volume of messages in the InBasket per day. You can see, you went from over 2 on average to 0, around 0, less than 0.1, which is a significant difference. That adds up. Every one of those messages is, especially if it's not just the time it takes to handle the message, which might be, a minute or less in some cases. It's the nuisance and the increased cognitive burden that you place on your clinicians. I'm going to turn it over to Betsy to talk about canceled orders.
Very good. And, one thing I kind of had been thinking about as well is that, interestingly enough, even though we dropped so significantly, we're still only in the middle 50th percentile of Epic customers, which tells me that we're not the only organization that has suppressed these automatically generated notifications. So definitely would encourage you that if you haven't done this at your organization, it is certainly not unprecedented to try to approach your HIM and compliance teams and see what you're able to do with that. So next we looked at canceled orders. So canceled orders, really, we actually found they were more than a nuisance. And why would we say that? So our Radiant team, our imaging team, they had a process. And if a patient no-showed for an imaging study, or for some reason they had checked in and then the system went down or something happened and they weren't able to get it, that team had an entire process for how to, number one, know if the patient needed to have that done, get the order back in place if they needed it, and they really took care of those patients. Our Beaker team, our lab team, they thought they had a process. So their idea of what their process was that all of the canceled, they had a cancellation notification, a reason, and then a notification came through to the provider's InBasket for all of these. The problem is it was not a very effective process, because the way that it was working, we had so many notifications come through and we got notifications for everything. So if I canceled one of my own orders, I got an InBasket notification that I had canceled that order. And so what was happening is there was too much noise, and the things that were actually important were not getting caught in the InBasket. So we needed to kind of figure out how can we better do this. So we went through all of the lists of cancellations for our lab orders, and we realized that there are, there's kind of 3 major buckets. There's ones that are clinician initiated, there are ones that are patient initiated, and then there are ones that are lab initiated. So ones that are physician initiated, you really, does the physician need to be notified of a physician discontinued lab? We didn't really feel that they did. Again, we worked with HIM, compliance, our lab team, our clinical teams, didn't feel that was important. Patient initiated, another story, right? So a patient comes in and says, well, I'll have all my labs done except for that one because I think it's going to cost too much money. That's important for that clinician to realize, hey, yeah, I'm signing off on 5 results, but there's one that's missing and you didn't catch it. So those types of things were important. And then lab initiated, some of those are important and some of them are not. There's a lot of duplicate orders. There's a lot of patients discharged, never received it in the lab, that type of thing. But then there's other lab initiated ones where maybe the specimen clotted, and so the test was not run. And our Beaker team did not have a process by where they would go and contact the patient. They would send a notification to the provider and then count on that provider to reorder the test. So what we did was we went through that list and we said, okay, which ones can we suppress? Which ones can't we suppress? We want to get rid of the noise. And this was our result in our first go round. So we had a pretty significant drop in the number of notifications. Since that time, there have certainly been instances where a cancellation has happened, a notification was not sent. The physician said, you know what, I should have received a notification. And so far, I think I've been involved in, I think, 2 of those since we went live with this over a year ago. And in both situations, the lab had chosen inappropriate cancellation reasons. And had they chosen the appropriate cancellation reason, the notification would have gone to the clinician. So it was really more of an educational opportunity than anything else, than a safety issue. And so our plan next is, as we get the resources and the time to do it, we want to kind of reevaluate again now those reasons for notification and look at them and say, okay, you know, are all of these still pertinent? And do we want to retain all of those? Chris.
Okay. Thank you. So the third notification message type that we thought we could address specifically was ADT notifications, admission, discharge, and transfer notifications. Now, there was a couple of years ago, there was a rule passed by CMS, I believe, that said that participating hospitals had to notify the care teams of patients about admission, discharge, and transfer events electronically. We turned that feature on, and that included sending it to our internal providers. What we determined was, number one, when we talked to other organizations, a lot of other organizations were not notifying their internal providers because they could see everything in Epic anyway. And we also actually had existing processes in place to route H&Ps, procedure notes, and discharge summaries to the primary care provider listed on the patient's care team. So for many providers, the ADT message felt really redundant and was just something they had to click through and was more of an annoyance. We left on external ADT notifications from external organizations because especially in the Chicagoland area, we have a lot of patients that flip between the other healthcare systems there. And that allowed our primary care providers to stay in the loop on their patients going to other facilities and what care they received there. But we did enable a feature that came with one of our recent Epic upgrades, which was to allow the end user to have more control over those notifications and turn them off completely if they desire, or to fine tune them a little further and decide which types of ADT notifications they want to get about their patients overall in their InBasket. And that was a huge satisfier for our clinicians because they really didn't love getting all of these ADT notifications. And some of our more conscientious primary care providers who were super detail oriented wanted both. They wanted all the other stuff that was coming in plus the ADT messages. And then others were like, nope, I got it. I'm on top of this. I don't need those additional ADT system generated messages because they're not as useful as some of the other methods I have to keep track of this. And so we put the control in their hands, which is one of the things we tried to do whenever we could in this process, is if there was a way for us to empower the end users to take more control over how they manage their InBasket, we wanted to do that for them. And this was just one small example of how we did that. So we've talked about those 3 message types or notifications that we were able to target specifically that came out of looking at the signal data and then looking at overall InBasket tune-up and then responding to feedback we had gotten from our clinical end users. Then we took the tune-up report and we, over the course of last year, we took some actions based on the tune-up report to help further reduce the number of system generated messages that might be redundant or not particularly considered not particularly useful by our end users. So one was to set automatic expiration dates for our notifications. So if you go to the next slide, you will see. So what we did is we tried to look at our notifications, all the notifications that go to InBasket, and decide which are actionable and which are informational, and split them up into those categories, and then set appropriate expiration dates accordingly. Prior to this, our expiration dates were way out. Some things never expired, and then some expired after several years. So those messages could sit in an InBasket a long time for for a person who reads it and then just leaves it there, like most of us do with our Gmail, for example. But we wanted to get rid of that clutter because number one, the InBasket will load a lot faster when you go into it, which is a satisfier and makes you more efficient. And number two, it just helps you find and focus on the work, today's work today, and not worry about all these old messages that are cluttering up your InBasket. So we set the actionable messages to expire and vanish in 180 days. And that allows plenty of time for action to be taken on them. And then some examples of that would be results notifications, medication refill requests are two big ones. And then for informational, we set those at a much shorter 45 days. And we worked with our compliance and HIM and risk and our frontline clinician subject matter experts who are users of this every day to come to these timeframes. And examples of those informational messages would be CC charts, for example, or those ADT notifications if they were still getting some of them, including the external ones they may be getting. So that's how we approached that, which greatly reduced the number of messages in everyone's InBasket. And then the other thing we did is we just retracted a bunch of these old notifications. So we got the automated expiration dates. So that's going forward. That takes care of any message that comes in from the date we implemented that going forward, right, in 2022. But what about all those old messages that are still sitting in the InBasket that people have hung on to, much like a cluttered Gmail inbox? And what we did there is we worked with our compliance, HIM, risk, all those people all those teams I mentioned, and we were able to retract more than 60 million. It's probably closer to 70 million at this point messages out of people's InBaskets, which is, you might say, well, those are old messages. They weren't having to deal with them anyway. But to be truthful, as I mentioned, they were slowing things down when they were trying to load their InBasket for a lot of these clinicians. And it was making it harder for them to find the things they needed to focus on more acutely in their InBasket. So it was a well-received retraction, let's put it that way. For the other two things we did for InBasket Tune-Up, I'm going to turn it over to Dr. Winga. Betsy. She doesn't skip.
I went the wrong way. I have to go up. Hold on. Okay. Sorry, I was rolling. I must have accidentally rolled my mouse the wrong way. Apologize for that. So the next thing that we wanted to look at was some of the open encounters that were out there. So our organization, being large, we had a lot of open encounters. And then we also wanted to look at automatic closure of encounters, right? So if a patient no shows, or if a patient cancels, or the situation where maybe a patient arrives and then leaves without being seen. There were a lot of times where those no shows or canceled appointments might have inadvertently gotten arrived. And then the clinicians had to go in and close those encounters, which was a big dissatisfier. So we wanted to be able to automate that and make it so that in those situations, the clinician did not need to go in and close the encounter. So we set up batch jobs to be able to automatically close any of those types of encounters. And then the ones that were left open indefinitely. So, the PSRs open a telephone encounter and then it gets passed around to everybody and then nobody ends up closing it. And that open encounter just sits there. And we knew that our clinical support teams, again, had hundreds of old encounters that had been left open at some point that nobody had gone back in and closed. And so we looked at a lot of different encounters. They certainly were not just telephone encounters. There were the growth abstracts and the external record authorization and external record like behavioral health ones and consent forms and et cetera. And so what we did was we set up a batch job that runs every night to automatically close these at a certain time. So for instance, with telephone encounters, if that encounter goes, I believe it's 60 days without ever being touched by a clinical person, so a nurse or a physician, then it is automatically closed in the batch job that night. Whereas every time somebody touches it and opens it and looks at it or does something with it, that time frame resets. And assuming if you go 60 days without even looking at a notification, it's probably not a very active encounter. So we set that batch job to run every night, and then we went through and we closed all of the old encounters that were already sitting out there. This took several weeks to do in the system, and we closed over 7.37 million encounters when we first ran that initial batch job. So we were very happy with that. So what are we doing going forward? So going forward, in the past, we had always had an integrated app team. So the way that our IT team is set up is that the InBasket to the clinical end users is one thing, right? I just go to my InBasket and I do everything in my InBasket, and it's one thing. To IT, it's a lot of different things. And so it has a lot of different owners. So you have MyChart, who's going to own the e-advice encounters and going to own the refill encounters. And you've got ambulatory that's going to own the telephone encounters, et cetera. You have HIM who owns other encounters. You have inpatient who owns some encounters. And so the actual InBasket is owned by this huge kind of multi-specialty group of IT, and they worked together so that if this team was making a change, all the other teams would say, okay, that's fine with us. It's not affecting us. So they coordinated from that standpoint, but there was no coordination. There was kind of no supervision of, yeah, that's a good idea. That's okay to do through the InBasket, or you know what, that's a really bad idea. An example I can tell you where this was working recently was one of our kind of outreach departments, pop health marketing, patient engagement kind of department, wanted to send a notification to any clinician who had patients who qualified for a certain program by their insurance. So that they could refer the patients to this program. And, we're like, that's not appropriate for the clinical InBasket. That needed some oversight to say, that's an educational opportunity to teach about new programs. That needs to come through other routes, other educational and other informational routes. That is not a clinical thing that needs to come through the InBasket. So we needed to have that kind of oversight. So what we did was we put together a group. We recruited participants from all of the app teams that had been involved in that integrated app team, and then clinical informatics, some clinicians as well, CMIOs, et cetera. And we put together kind of a core team who really needs to meet regularly, and then the ad hoc team who get more informational, whatnot, just so that they're kept up to date on things, and they are welcome to attend any meetings that they want. Now, we really just stood this up within the last 2 or 3 months. And the types of activities that we're looking at doing is, again, approving proposed messages. How should we use the InBasket? Should it be used as general communication? We don't feel that it should. It should be pertinent clinical information for the patients. We also, we have plans to review our routing schemes. So right now, because of the way that our organization kind of came together, we have a couple different routing schemes, which can get kind of confusing. So our legacy Wisconsin teams have one, our legacy Illinois teams have another, and that can get kind of confusing. So what we would like to do is be able to really standardize those workflows and get these notifications routing to the most appropriate team so that everybody's working to the top of their license, and these aren't all just coming to the clinicians InBasket. We just recently, mid-December, we had an upgrade and we took Epic's new InBasket, their redesigned InBasket. And this team has really been integral in preparing for that, in testing it, helping with the education and the communication. That's leading up to the change. And then since the change, helping with a lot of the decisions there, we chose to disable the reply and reply all feature in 5 of the baskets. We didn't feel that they were appropriate because they were being misused. And so this team has really helped us with education and finding opportunities and, helping to deal with disgruntled clinicians who aren't happy with that decision. And we're still dealing with that a little bit, but the team has been very helpful. We also want to comb through Signal for different opportunities, and a lot of the gold star and honor roll possibilities, they involve InBasket. So trying to clean up the data as well. So for instance, when we go in and look at our Signal data, it looks to us like our surgical subspecialties, and so like GI and some of our different surgical specialties, urology and whatnot, it looks like they get an enormous number of these messages called event notifications. And it like hundreds of thousands. And, Chris and I were like, this is just ridiculous. Like, what are these notifications? We don't even know what they are. Well, as it turns out, the clinicians were actually not receiving those notifications. The notifications were being generated, but their folders were being suppressed from view of the clinicians, but they all still showed up in our Signal data. And so all of that volume of messaging coming through our InBasket still reflected poorly on the organization, even though no clinician was actually seeing that. So we really said, we need to make sure that our Signal data, especially if we as an organization, if we're going to be judged in some ways by our Signal data, that data needs to be accurate. It needs to be clean. So let's go through and make sure that we're doing that. So this is kind of the group that's, ideally set to be able to do that. And I believe that is the end of our presentation, of our designed presentation. So we're happy to take any questions.
Awesome. Looks like we have one already from Katrina. Katrina's curious, we are also looking to close a large number of appointments marked as no-show and canceled. Do you mind sharing what specific batch job template you used? Thank you.
Ooh, well, I can tell you that I am not 100% on the specifics. I do know that we have some of our application analysts on the call right now, and they may be able to help put some in the chat as to the specifics. Chris, do you know any of the specific batch jobs that were used?
I don't know off the top of my head. I was just thinking about that, but if we can't answer it during the presentation, we can get those batch jobs and then share them.
Yeah, we're happy to share.
With Zach and everyone else from HIMSS, and they can send it out to anyone who attended.
Perfect. Some other questions here that just came in. Curious about how you marketed or talked about kind of these efforts with your end users and your clinicians. Kind of to what level did you tell them this was going on? Kind of what was the communication or marketing plan that happened?
So that's a very good question. I'm sure that everybody struggles with communication to their frontline clinicians because email is just not an effective way to have them really understand and absorb anything. So what we did was we went through all of our normal educational paths, right? So we went through our bulletins that we put out and our weekly newsletters and our monthly newsletters and whatnot, and had it posted everywhere. And then when we started retracting some of these expired notifications, we started in folders that weren't quite as important, because the theory was when all of a sudden their CC charts folder goes from 500 notifications to 25, they're going to go, what the heck is this? They're going to pay attention and they're going to ask somebody about it. And then that somebody would hopefully know what was going on and be able to educate them. So we identified the 5 folders that we felt were the most pertinent, that people would actually like try to save things in to follow up on in the future. And those were results, result messages, patient calls, like those types of much more actionable folders. And we saved those till the very last. And we went through and we did everything else, hoping to kind of generate some of that attention from it actually happening.
Right.
Yeah.
Oh, sorry. I was just going to chime in and say that basically what we did is with the less critical folders, we generated buzz, so to speak, by getting people's attention by expiring those notifications. And then, as Betsy said, that got people's attention. And then at that point, we also pushed out some additional communication, right, to through various channels, and got in front of various clinician leadership meetings, and use that as an opportunity to say, hey, you may have noticed, well, that's what this is, and it's going to keep going. So just for your awareness, and people actually paid attention then because they had already seen some results of that. So that really helped us, because putting it out ahead of time, although we did that because we always do that, it seemed like most things, it was a theoretical change. It was a change in theory that hadn't happened yet. So people are like, yeah, I'll believe it when I see it, sort of. And once they had seen it, they did believe it, and they were much more likely to snap to attention and go, oh, okay, well, I guess I should listen to this, because this is actually happening. Sorry to interrupt.
No, you're good.
Another question from Stephen, and just thinking about the different ways in which users kind of use the messaging function. Did you look at any kind of training different ways for providers or others to remind themselves to call a patient back, or to save a message that they want to come back to? Just thinking of sometimes people that just keep those things sitting there. Any kind of training or change in practice that you'd recommended there?
We did. One of the things we did is we re-emphasized the remind me feature in which is part of the Epic functionality that we found was underutilized, and I was surprised at how many people just didn't realize that it was something they could take advantage of and how it worked. So we really, in conjunction with this, tried to have a campaign that specifically focused on that functionality as one of the big alternative and acceptable tools to use to keep track of things for patients if you really needed to be reminded about things. And then also using features within the InBasket too that would make the message pop back up in a certain amount of time, or in the case of results, if you wanted to know that a patient hadn't viewed results, using those tools when you're releasing results to the portal, that sort of stuff. I don't know, Betsy, if you want to add anything to that.
The only thing I would add to that is that we also took this opportunity to kind of re-educate clinicians on what the InBasket should be used for, right? So it should be used for clinical things, not for email type information and whatnot. So a lot of people said, well, I save all these messages because it tells me who to refer these different types of problems to. Well, that's not really appropriate for the clinical InBasket. And, one or two of those across an organization, fine, not a big deal. But when you've got every clinician doing that, that adds up to a lot of volume, and then that can potentially affect the system performance. So trying to kind of help gear everybody more towards, away from the InBasket is not email. It's not supposed to be email. It's clinical information.
That was one of my questions as well, as we were going through, of just, Betsy, you had mentioned, finding some people that were a little upset that reply or reply all had been removed in some cases. And I think sometimes with stuff like this, you find the interesting workflows that people have designed for themselves, some of which are probably really good and some of which could be done elsewhere. A follow-up just from McKenna, and then Donna, I see you also included a question. So McKenna mentioned, my organization is advertising the bookmark feature as a way to mark messages, results, notes, encounters, and the like to save for later. It's a great way to save patient information for the patient's future visit. So again, I think, kind of in line with the remind me feature of there might be tools or things available that people could use and really like.
That's a great tip. I am a user and lover of the bookmark feature. We didn't emphasize that with this, but it would be a great tool to emphasize in this work as well. We had last really spent some time publicizing that feature back when we were promoting how to be more efficient in chart review and finding what you need, and promoting chart search, and also, but also bookmarking things that you're going to have to come back to over and over and over again on a specific patient, like a critical imaging study that has, findings on it that you constantly refer back to. That's a bookmark. That's a bookmark slam dunk in my mind, and that's this kind of stuff. So that's a really good tip, and thank you for bringing that up.
You bet. Question, I think, around kind of prioritization or thinking of all of the different messages that folks receive and what's most important to address. So question about if you did any color coding or any kind of bold or any kind of way of calling out those messages that are kind of critical and shouldn't be missed for the clinical staff. And I know some of that might be more on the vendor question side, but just curious if you employed any kind of unique formatting ways to draw attention to important messages.
We did not, and I'm not aware of any that can be automatically employed, but certainly would be interested in reviewing that if there was.
And then another really good question. So what is next for Advocate Health as you continue to improve your satisfaction and efficiency for physicians and for nursing professionals? And you touched on kind of a little bit of the future state, but as you look at 2023 and continuing to grow your footprint, anything else that would be interesting or useful to know about?
I think that one of the big opportunities for us that I sort of alluded a little bit to, but to expand on it, is with this combination with our new Southeast region, former Atrium Health. We have a real opportunity because they are also on Epic, but a lot of them are relatively new Epic customers. So we have an opportunity to learn from them about what has been working, because they took a different approach than what we had to take when we combined Advocate and Aurora, where they were able to push into a Epic system that was more out of the box, closer to foundation. And they've had some successes, as I understand, and they've also had some things that were more challenging for them to deal with. But my hope is that we can benefit from this combination by learning from each other collaboratively to say, okay, what did you do that really worked to improve your clinician experience with InBasket or any aspect of the EMR? And here's what we did and what we found worked, and share those learnings. And then as a result, both, in our combined organization come out the other end better off for all of our clinical end users and clinicians that are in the system all day long.
Kind of follow-up, I think, and it was related to the idea of the folks who are using the system all day long. I think a lot of this is understandably very provider focused, but is there any specific work or kind of any part of this that has impacted some of the other MAs and nursing staff and others who are also spending a lot of time in the InBasket?
Certainly, yeah. A lot of this and a lot of the different initiatives that we want to look at of helping everybody work to the top of their license in their InBasket is geared to help, from all aspects of the team. A lot of the chart closures is more beneficial to our clinical support teams than to the clinicians. A lot of times they're the ones who are opening, say, the telephone encounters or the medication refills and whatnot. And they're the ones who kind of forget to close them sometimes, or they don't get closed. And so it's their InBaskets that get a little bit mucked up sometimes. So yeah, definitely looking at the whole team.
Yeah, definitely thinking about how everyone uses the InBasket. And really, whenever we think about anything, I think a really important aspect of this clinical InBasket oversight committee that Betsy mentioned earlier is it is multidisciplinary across HIT and clinical and operational. And one of the guiding principles, and the guiding principles of our work so far on the InBasket has really been, if we're going to change something, if we're not able to completely remove a message type as a burden, we need to think very carefully about what we're going to do if we're going to shift that to another level of the team or another member of the team. So for instance, if we take a message And the easy thing would be like, well, just send it to the nurse or the MA instead of the physician or nurse practitioner. Well, the problem with that is then already overloaded nursing and medical assistant colleagues are now even more overloaded. And so we have to be, the answer is not to just, pour it all downhill, so to speak. It is to think critically about, is this even needed at all? And if it is, who is the right team member for it to go to? So it goes to the right person in the first, and doesn't have to bounce around to a bunch of different team members to ultimately end up in the place with the person who can actually most efficiently and effectively handle the message. We have examples too where we've had to think about messages that were going to our MAs or our nurses that they can't handle. It's just not within their scope of practice or their licensing that they can actually do that. And those had to be routed to the clinician, and that's appropriate. But that's the kind of stuff that before was just a burden on the nurse or MA, where it was cluttering up their InBasket, and ultimately all they were ending up doing was sending it on to someone else, get it to the right person in the first place. And you're decreasing their burden, and you're not really increasing the burden of the clinician. You're getting it in their hands faster. They were going to have to deal with it anyway. So they're not seeing that as an increased burden. They're just seeing it, as a direct line rather than, having to wait for it to come to them.
And I think that speaks really nicely to the governance piece that you two discussed of whenever you're considering, is a hammer the right tool here? Is messaging or InBasket is the right tool to figure out, if it is, kind of where it lands and who should work on that. The final piece, and just kind of the final question, thinking about some of the message types that tend to come in a lot, and I know obviously there's a lot of focus on this across the industry right now on kind of how to handle the patient advice requests and the volume that has brought with folks obviously being really connected to their care, but also being able to message a provider 24 hours a day and get an answer. Any work that you've done kind of around how you handle those messages, any best practices to share with the group on things that worked really well, knowing that trend will probably continue as something that we see a lot of.
Right. So I can speak a little bit to this. We have a separate e-visit program where patients can go, and it's kind of like an e-visit urgent care. So they're not sending a message to their own clinician, but they can go and they can choose to do an e-visit for mild or minor low acuity issues. That has not helped. We've had that for years, probably 10 years almost. And it has definitely grown, and we do bill through insurance for that now. It used to be retail, but we just switched to billing through insurance. So that hasn't grown a lot, but that is one outlet for our customers. As kind of a little bit of part of that, our consumer experience team are also right now going through screen by screen the process that patients go through to send patient advice requests. And we are trying to identify all places where we could help send the message to the appropriate place. So if it's an appointment, send it somewhere appropriate. If it's a med refill, send it somewhere appropriate, to try to help kind of delineate a little bit of what's coming into the clinician's pool messages. We're also trying to be very clear for patients, and everybody knows that this is very difficult, but trying to communicate very clearly what is appropriate to send as a message and what is not appropriate to send as a message. And finally, we have a couple of pilots going on that have just started within the last week within the organization. One is of doing scheduled e-visit follow-ups. So for instance, you start a medication, you want to do a follow-up offer to the patient. Would you like to do this by an e-visit? We can do it in 3 months if you'd like. They say, yeah. And then how does that work? How does the patient receive the questionnaire from the e-visit, finish it, and send it back? So that one has just started. Another pilot has just started for converting an acute message to a billable e-visit, and doing that in a process where the patient is involved and agrees to want to switch over to that. This is certainly something that I think there's some fairly controversial decisions that are being made, and controversial both directions, right? So across the country, you hear about some of the big organizations that are just saying to their patients right up front, hey, anything you submit, we might charge for, just FYI. And how does that go over versus the people who don't charge for it? And I don't know that there's a right answer or a wrong answer there. Right now, we do not do that. I don't know that we never would do that, but there's a lot of considerations that need to come into that decision.
Yeah, and I'll just add that from a perspective of getting the messages, the patient routed to the right way to contact us for the purpose they're trying to contact us for lack of a better way to say that. Our vendor Epic is also doing some work to help us with that as well, and we hope to take advantage of that work. And in our recent combination with our new Southeast region, we are starting collaboration with them to work through just what Betsy was saying about how do we address this, the massive influx of patient advice requests, and do we start converting more over to a type of e-advice or to e-visit, excuse me, or do we go another path? How do we offer that to the patient, engage the clinician to help them make a decision together, where the clinician says, yeah, this is going to be more involved. I'm going to offer to convert this to an e-visit, and then that means they'll be charged. And this is just, for example, the patient can say, no, thanks, I'd rather make an in-person appointment or a video visit maybe, or sure, this is easier, more convenient for me. And we know that some patients would choose the former and some would choose the latter. So that's a collaborative effort. We're one of the earliest collaborative efforts in our new combination that we're working on.
One other thing to add, one of, what I repeat over and over again to clinicians is, you don't have to answer an e-advice, right? Your answer can be, this is too complicated to discuss by chat or in writing. I need you to come in and have an appointment. There is nothing wrong with that. And, when patients send in a photo and, our dermatologists say, how can we be expected to make a diagnosis on a photo? You don't have to. Nobody's forcing you to. The patient's communicating this to you. If you feel it's appropriate, you can do what you want with it. If you don't feel it's clinically appropriate to make any of those kinds of decisions or evaluations, then ask the patient to come in and be evaluated, period. And I think just kind of reiterating that and helping our clinicians remember that, oh, yeah, I can say that if I need to.
Marvelous. Well, thank you both so much for sharing your wisdom and kind of the journey that AAH or Advocate Health has been on and continues to go on. I think some wonderful learnings. As always, thank you to all of you as webinar participants. Thank you to our sponsors. A couple upcoming events just to share from the greater Illinois side of the house as well. And of course, our HIMSS Global Health Conference that we'd love to see you at. And then again, thank you for attending. There will be a survey that will populate. Please complete that survey. We do use it to inform kind of our future programming. Completing the survey will also mean that you get the CEU form and the recording after the call is complete. But thank you so much, Dr. Winga and Dr. Jamerson. Thank you so much to all of you for attending. And thanks to our greater Illinois and Wisconsin HIMSS friends for collaborating.